Hello everyone, joining now today's webinar with Mervyn Waldman. Welcome back to this
Can everybody hear me clearly? I hope so.
yeah. Yes. If anyone has got any questions, I can read them at the end, I think, to Mervyn, or Mervyn can read them from this. We better leave them for the end. Yes, Mervyn?
Very good, yeah. So tell me when I should start, and I'll be happy to begin.
Okay. It's just, okay, so we have this great webinar today with Mervyn Waldman from Israel, talking about the biomechanics of the pelvis, which is a wonderful subject to introduce the conference that we have in 2 weeks in London. Yes, will be the spine as the axis of life, and we have 4 or 5 great speakers. We have Chris Batten. He will be doing a taster day workshop, introduction to classical osteopathy. He will be on Friday 28th, and then on 29th we have 2 workshops with 2 of the guests that we have, Christian Fossum and Dr. Eric Snyder. He comes from Kirksville. And then on the 1st of March, we have the conference, the ICO conference, with, again, Christian Fossum, Eric Snyder, and then we have Tim Sparrow from the ICO, and Dr. Maribel. She's a doctor in anatomy from Barcelona. She will be showing some dissection pictures that they do in Barcelona. And then we're more than happy to welcome everybody in the ICO conference. Most of you have been through the website of the ICO, so tickets are available still there if you want to come along. And yeah, nice to see you. And now I will leave everything to Mervyn and this amazing lecture. Thank you, Mervyn. All yours.
Thank you. Well, I hope it will be an amazing lecture.
I hope so.
I hope it'll surprise people and cause us to question some of our very basic tenets. But I promise you it ends on a very up note. In fact, it brings us all the way back to JML, Littlejohn. And I hope that the lecture will show you how much I do appreciate his clinical approach, to such a degree that it is the only approach I now use and have been using for the past 20-odd years in hospital practice with some of the most difficult patients imaginable. Anything else would have been disastrous, in my opinion, and I'll indicate why in the course of this lecture. But I'd like to start off with a rather amusing little film of a few seconds. It's a minute or so. Let's take a look at this, just a moment. Okay. It's a machine that is supposedly designed to determine and understand the mechanics of the pelvis and the sacroiliac joint. Take a good look at it. Because in fact, it is the nearest thing I've seen in a while to the Spanish Inquisition. It is totally unphysiological as to what it implies is going on at the sacroiliac joint. Were anything like this to be happening in real life, it would inevitably cause the most disastrous rupture of ligaments and be as painful as the Inquisition. So we're going to look at some of these theories, hypotheses in fact, because they've never been really based upon evidence that could be called scientific, and suggest that we have to look at the subject rather differently. So, just let me come out of that, and let me come back into my PowerPoint. And wait a minute, I think I've made a mistake somewhere here. Hang on a second. You want share screen on my PowerPoint, and we're almost there. Good. Is that clear for everybody?
Yeah, all good.
Good. Okay. This diagram has been a wonderful instrument for me to teach with, because it's dynamic. You can move it in all sorts of directions, and allows me to explain to students the perhaps obvious principle, but long and often forgotten, that no anatomical structure functions in isolation, not least the pelvis. When you move any part of this structure, every other part has to accommodate and adapt to that one part that's been moved. And the fact is, if you look at this structure, it's describing the fact that mechanical load encountered anywhere in the body is distributed through a continuous network, as you know, of fascia, ligaments, and muscles that support the entire skeleton. Okay. There is a phenomenon with the erector spinae. They're almost silent when we stand still. When we begin to move, they begin to brace up the body. They shore up the vertebral column against gravity, but only during movement. And they do so converting the spine into an animate beam, you could say, with the pelvis as its firm supporting base. Now, it can only do that in partnership with the semicircular canals of the inner ear, the occipito-atlantal articulation, and what isn't shown here, but extremely important, the arches of the feet. That conjoint integration is what maintains our balance, and more so, the changes of equilibrium, and all that in relation to the spinal column. Now, all those things, that is, the inner ear, the occipito-atlantal articulation, the arches of the feet, is dependent on adequate motor control patterns which activate partially coupled muscle groups. I'll say it again. It's dependent on adequate motor control patterns that activate partially coupled muscle groups. Let's look at some of them. You're familiar with most of them, but we rarely think of them as coupled muscle groups. Let's consider latissimus dorsi and the gluteus maximus as a coupled group. Let's look at the erector spinae and the hamstrings. The erector spinae and the hamstrings as a coupled group. The pelvic floor muscles, possibly some of the most neglected muscles in osteopathic work. The transverse and internal oblique, superficial and deeper coupled muscle groups. The extremely important quadratus lumborum, which does and creates havoc sometimes on what we think are changes in the mechanics of the pelvis, or in the positional changes of the pelvis, often giving us a very considerable illusion of movement of the pelvic ilia. Consider the piriformis and consider the psoas. There's the little piriformis. We're going to look at that a little more closely in a moment. But what you ought to notice here, with particular relevance for this lecture, is that many are connected directly to the ilia or indirectly spanning it like the psoas, and thus profoundly influence sacroiliac function. So it's most important to realize that when coupled muscles are more contracted on one side, they often produce the false appearance of an asymmetric pelvis, such as one ilia appearing higher. For example, quadratus lumborum contracting on one side more than the other. Or it can give you the impression of a nutated anteriorly or posteriorly ilia, a moving ilia, directed ilia. So we're going to return to this very important diagnostic illusion a little later in the lecture. Let's take a closer look at some of these coupled muscle groups. Smooth conjoint coordinated function is the key. It's the key to stress-free and painless pelvic function. These are two extremely important coupled muscle groups, the piriformis and the psoas. Try to imagine what's going on in relation to the pelvis when there's an abnormal balance of one against the other. Consider the balance of the erector spinae and the gluteus, with piriformis in between them, all three acting as coupled muscle groups, again attaching directly to either the ilia or the sacrum. More intricate, the balance of the piriformis and the obturators together with the quadratus externus and femoris. Again, try to imagine abnormal hypertonicity or hypotonicity on one side compared to the other, and its effect on the ilia. And most important of all, there cannot be any change in lumbar function without it involving the psoas major. Iliacus is dragged in, and inevitably there'll be undue stress on the ilia. The play of the tensor fascia lata against the adductors, again producing major stress on the ilia. And last but not least, the piriformis in relation to the sacrum. Now, you can't separate these muscles into distinct functional units, as they always work in an integrated manner with their coupled neighbors. And you could say that the attempt in osteopathy to restore their coordinated function, to whatever degree the age of the patient or the health of the patient or the comorbidities of the patient permit, is probably the primary goal of osteopathic classical treatment. The attempt to restore their coordinated function. The pelvis, its sacroiliac joints, and their myofascial and ligamentous attachments are designed, first and foremost, for the effective load transfer between the spine and legs. Body weight. Sorry, that shouldn't have happened. Sorry about that. Clicked unruly. Body weight. But notice the action and reaction from the ground up, all of which is transmitted partially through the sacroiliac joints. It's a load transfer that involves moment-to-moment adjustment of the pelvis to the imposed gravitational and weight-bearing forces, as well as the reaction to the forces transmitted from the ground up. So what assists this balanced transfer of mechanical energy from one region of the body to another? It's joints with their associated entheses, that is, the connective tissue between tendon or ligament and bone. And all that is dependent upon varying degrees of viscoelasticity in the soft tissue attachments. Now, the degree of this viscoelasticity, the nature of this viscoelasticity, the manual feel, the palpatory feel of this elasticity is one of our key diagnostic tools. And the improvement of this viscoelasticity is one of our chief treatment goals. If we can appreciate the effect of undue stress on the biophysical nature of viscoelastic structures, it will help us understand the potential source of most pelvic pain. Not least because embedded in these tissues, in these viscoelastic tissues, apart from mechanoreceptors and proprioceptors, there are also pain-transmitting primary afferent nociceptors. So all three, mechanoreceptors, proprioceptors, nociceptors, play a vital role in modulating the efficient load transfer, chiefly through neurosignaling pathways. It's important to remember, however, that this modulation can be significantly dysregulated. We all know how, through strain, injury, inflammation. And that's the clinical condition in which we find many of our patients. Now, to modulate efficiently load transfer by the sacrum, the pelvis, and the spine requires a total body response, focusing on and treating singular anatomical structures such as the pelvis to treat lumbopelvic pain, rather than considering the spine and pelvis as an integrated, interdependent biological structure, inevitably blinds the operator, blinds him or her to the larger picture, and can easily harm the seriously ill or disabled patient if it's incorrectly treated. Littlejohn summed up the attempts to integrate and stabilize the kinematics of the body in his remarkable way of using the minimum of words sometimes. He called it the restoration of balanced mobility. 2 words to sum up almost all that we do day in and day out in osteopathy. The attempt to restore not just balance and not just mobility, but the two together. One alone is insufficient. It's unphysiological. And it's only likely to be partially successful, if at all. So balanced mobility. We could spend a whole evening just on those 2 words and their significance in terms of clinical practice. But it's neither one nor the other in isolation. That is where so much of osteopathy goes wrong. That's where so much of manual medicine goes wrong. The attempt to focus just on mobility. And forget, it's got to be balanced mobility, integrated with the rest of the body. But there's one more aspect that's very neglected in modern osteopathy. Treatment and rehabilitation in the attempt to restore balanced mobility should be a mutual effort made by both the operator and the patient to integrate the two. What do I mean by that? Look, the operator can employ an extensive range of treatment techniques to match the needs of the patient at each stage of rehabilitation. But it also requires a patient to be willing to learn and consciously apply improved body ergonomics in daily life, if anything beyond temporary relief is to be expected. You're not going to change this with any amount of clever technique without also engaging the patient consciously, daily, to try and improve ergonomic habits which are faulty. You can give the best treatment in the world, but if the patient goes back to doing this sort of thing, it's unlikely to give any lasting significance. So if you also include carefully spending some time re-educating the patient using your hands, they have to get the correct feedback. They can't just see it or visualize it. They have to feel it through their muscular system. Then we will be addressing simultaneously not only the soft tissue attachments and articular structures that we are treating manually and trying to improve the aberrant neuronal signaling from their dysfunctional state, but we'll also be recruiting supratentorally, that is, the patient's conscious brain, through repeated hands-on instruction in ergonomic re-education. Sorry. When it comes to treatment, it mustn't be too vigorous. In fact, Littlejohn emphasizes this time and again. The lighter the treatment that satisfies the condition, the better, in order to avoid bruising or straining of soft tissues and thus further irritating already upregulated nociceptors and mechanoreceptors, which are often, in addition, already discharging aberrant ectopic signals. The treatment should therefore be distinctly sedative, while simultaneously trying to re-establish rhythmicity of movement to enable coordinated conjoint action, especially in regard to coupled muscle groups throughout the body. Notice, in this particular case, the operator isn't just applying a force on the sacroiliac. His hand is doing something extremely important. It's trying to detect if there's any alteration in the smoothness of a vector passing via the legs as levers to the hip, across the sacroiliac, and right across underneath his elbow to the sacroiliac on the other side. He's playing between this whole conjoint arc of movement to determine whether it is a smooth, rhythmic, articular function or whether there are aberrant resistance, points of resistance within that range of movement. And all that in relation to the soft tissue attachments of the legs, those coupled muscle groups that we looked at earlier, whether it's the hamstrings or the rectus, whether it's the piriformis, all of which are under these two hands of the operator to determine the play of forces between the levers and the local articulation. When I first saw John Wernham applying these maneuvers as a student, I hadn't got the faintest idea what he was doing. It took many years for me to understand this principle of conjoint action in diagnosis and in treatment. But never, never have I been more grateful than in the past few years in my hospital practice, where I have to rely on these quiet, sedative, articulatory techniques to deal with some of the most difficult and sometimes very tragic cases that one sees in hospital work. And I fully understand why Littlejohn would have nothing to do with bone setting, pushing bones from one place to the next, using force. Because inevitably he was treating some very seriously disabled or very seriously ill patients. And you can't do that in those patients without causing them serious damage. So, when these maneuvers are being done, it's time and again an attempt to downregulate pain-generating neural signaling. When I have a couple of doctors coming into my room in the hospital, they're new in the department, they want to know what's going on, they want to try to understand what I'm doing. That's the language they understand, and it's perfectly logical, and it's perfectly clear, and it's good medicine. I'm attempting time and again with all sorts of patients as one of the main aims to downregulate the pain-generating neural signaling coming in from dysfunctional or irritated mechanoreceptors, proprioceptors, and nociceptors. When you say those things to a doctor, they're on your side. They're listening. They'll respect what you're doing. There is no place, I'll say it again, there is no place for pushing a bone into place, whether it's the neck or the pelvis. It's unphysiological. The forcefulness inevitably tears or ruptures microfilaments in myofascia and in ligamentous structures, and has nothing to do with integrating the conjoint activity of the neck or the pelvis with the rest of the body anatomy. Littlejohn put it so well when he writes, let's look at this carefully. An osteopathic lesion is neither a bony malposition nor even a maladjustment, and should not be regarded as anatomical, but physiological. I shall be making this point very strongly throughout this lecture in a number of ways. He further writes, in correction, it's not physiological to thrust or force a vertebra into line. It is essential to remember that we must rectify the whole gravity line before we can adjust the local lesion or keep it adjusted. That is a world away from what is often being done in the name of osteopathy today. He further said, the lesion is a disturbance which plays against the force and line of gravity and the gravitational points in the spine and body. The rhythmic, sedative, articulating methods developed by Still and Littlejohn in rejection of bone setting is primarily, this is very important to understand, a highly refined means of diagnosis, which can only then, and it does, flow easily and naturally into a treatment modality as the operator meets and attempts to overcome loss of rhythmicity and points of resistance. Again, language which any physician can understand. The correlation and the coordination of the articulations of the body is most naturally achieved through the gentle yet surgically precise use of long leverages, which serve to engage as many attachments as possible, especially coupled muscle groups that were illustrated earlier. This is done to ensure as broad and comprehensive a diagnostic picture as possible, as well as in treatment, engaging an extensive area of conjoint structures. Most interestingly, it also ensures the minimum risk of injury to tissues, as resistance or aberrant rhythm or pain indicate to the operator the need to modulate his treatment forces from second to second. You cannot think of other things at the same time and practice this kind of osteopathy. There's some wonderful stories. McConnell relates as a student of Still's how Still would literally throw a patient out of the class and out of the school if he caught them not concentrating while practicing. He demanded total concentration, and he was so right, certainly when you're treating difficult and sick or significantly disabled patients. What does treatment success then depend on? It's quite simple in principle. Bringing it out into action is a lifetime study, but it depends on the extent to which we can restore what I've said just before, the rhythmic, integrated conjoint activity of the soft tissue attachments to the skeletal structure. To the degree that we can achieve that, we have, to some degree, succeeded in our treatment. It can be very minor, but it can make the difference between an elderly lady being able to shower by herself again, or being able to walk down to the local shops for a bit of grocery, or being able to raise that limb to get onto a bus, and not be housebound. It doesn't have to be a very large improvement. It can be 5%. And that's significant, perhaps, in a person's life in terms of pain relief and in terms of function. Using the limbs and their attachments as levers, as you know, activates the peripheral nervous system, which in turn produces a massive afferent sensory input discharge along the mechano-proprio and nociceptive pathways, going straight through to the dorsal root ganglion, to the dorsal horn, and to the central autonomic and immune systems. That's a lecture on its own right. But if these leverages are applied accurately and of a non-invasive, sedative, rhythmic nature, they can have a profound effect on lowering upregulated nociceptive and ectopic discharge. And neuromodulation is the key when it comes to aberrant sympathetic activity and circuitry. Now, carefully controlled, repeated passive movement of the limb leverages, directed, and this is very important, you can't just throw a limb around and expect that to have any significant effect. It has to be directed accurately against the fulcrum set up by the operator's other hand, applying relative fixation to a vertebra or to an articulation, and is the hallmark of classical osteopathic technique. Using that combination is in some ways quite similar to the picture on the right of active motor rehabilitation training. That too attempts to generate a re-educational afferent proprioceptive input to spinal cord relay centers and, most important, cortical motor centers. Returning to the pelvis, now comes the spice of this lecture. Right, well, this is either you're going to cut me off or you're going to listen and wonder how I've been allowed to give you this lecture. But I promise you, I gave you all that stuff in the beginning to show you that osteopathy is more than alive and well, despite questioning certain facts and fantasies, or what I think to be fantasies. All right, so here we go. Returning to the pelvis, let's take a close look at some of the morphological and dynamic characteristics of the area that can be easily a means of leading us to misdiagnosis and to mistreatment, and calls into question some of osteopathy's most beloved dogmas and theories regarding the pelvis. Over the past century, many scientists have shown an interest in the structure and function of the sacroiliac joint in relation to movement and pain. And these studies include many important facts that have brought to light many misconceptions. One of the most contentious issues has been the mobility of the joint. Now, the sacroiliac joint is an intermediate joint in that it has the characteristics both of a freely mobile joint, diarthrosis, and an ossified joint, a synothrosis. In the light of the massive, well-developed ligaments and the irregular form of the articular surfaces we're going to look at shortly, it's been concluded that movement, for example, in this particular very serious research study, it's been concluded that movement is barely possible, except in the case of pregnancy. Carefully conducted radius stereometric analysis puts sacroiliac joint movement to be, on average, a mere 2 degrees. This probably explains why the results of tests of inter-observer and intra-observer palpation consistency has been so embarrassingly poor. It's so difficult to feel 2 degrees of movement. And why orthopedic and osteopathic manual tests have very low sensitivity and specificity ratings. What appears to be moving gives the appearance of being a sacroiliac joint, but rarely is. In fact, it is the large movement of the pelvis relative to the hips, such as in flexion, extension of the spine going forward or backward, the rotation, the movement occurring through and around the hip joints, that gives you the impression of a nutated ilia, one way or the other. Imagine doing this to yourselves in the standing position. You can almost visualize the nutation of the ilia. And it's in relative to the hip, but it gives you the palpation illusion that the sacroiliac joints are moving and repositioning. I'll just give you a few more moments to look at that. So as I said, the movement is chiefly through its, I shouldn't have just shown this, but just keep in mind the previous picture. I don't want to disturb the movements of the slides, but it's chiefly a movement of the pelvis relative to the hips, through the trochanteric joint, almost none happening in the sacroiliac joint. Now, there are exceptions, as I said. The pregnant woman is one of those, or, and this is important, those with connective tissue disorders, such as Ehlers-Danlos syndrome, where the hyperflexibility does create more sacroiliac movement than 2 degrees, considerably more. Now, the normal but tiny sacroiliac joint movement of 2 degrees is most likely made up almost entirely of the viscoelastic stretch within these powerful tensile ligaments that firmly bind the joint. That movement is probably within those very elastic, viscoelastic structures. It is the abnormal loss or increase in the hyperflexible patient of the viscoelastic tension and flexibility that may be pain generating and can be one of our chief diagnostic parameters and the object of much of our treatment of pelvic dysfunction. What does it usually involve? The pathophysiology of strain, good old-fashioned strain, as does almost all joint or somatic dysfunction, according to Littlejohn. The old-fashioned osteopathic lesion, according to Littlejohn, is nothing more nor less than a degree of strain, with the pathophysiology that accompanies it. So, for these ligaments to have healthy viscoelastic consistency, it requires that they're made up of the normally proportioned components of principally collagen, as you know, plus proteoglycans, elastin, and some other proteins and glycoproteins. But all that can change. Any significant change in the biochemistry as a result of, for example, strain injury or chronic weight-bearing stress or collagen disease will significantly affect the biomechanics of the pelvis. And more importantly, or most importantly, it will influence prognosis. That is the time required and that can be expected for any degree of recovery. A time that is often measured in many months. In fact, Andrew Taylor still felt that a serious ligamentous injury may never fully heal and can remain a lifelong source of pain and dysfunction. So, the ligaments, together with important controlling muscles and their attachments, together with ground forces coming up from below bring about what is called the close packing and forced closure of the sacroiliac joint, which is so essential for its stability. But at the same time, ligaments provide an essential degree of elasticity. They also firmly yet dynamically support the upper body, providing both stability as well as acting as a platform for the three large levers acting on it: the spine and the two legs. So, the pelvis can be considered, in fact, as a force transducer. The sacroiliac joints hold and transfer the weight of the entire upper body from the sacrum to the hips and the legs. But don't forget, these are, in addition, important sensors of the large force streams between the trunk and legs. And some of the largest and smallest muscles of the body are involved in this sensing. So in this respect, you could call the sacroiliac joint as a multi-directional force transducer. But there are two further essential aspects of the biomechanics of the joint that ensure its stability. Its articular surfaces have the highest coefficient of friction of any diarthrodial joint, which of course enhances its stability against shearing. And secondly, the keystone-like bony anatomy of the sacrum further contributes to stability within the pelvic ring. Let's look at this more closely. At its base, sacrum is wider superiorly than inferiorly, so it gets wedged and locked between the ilia, preventing downward movement. But it's also wider anteriorly than posteriorly. It's wider anteriorly than posteriorly. It prevents forward slipping as it gets stuck between the ilia in this forward direction. So the combination permits the sacrum to be well and truly wedged cranially and dorsally into the ilia within the pelvic ring. It's obviously an adaptation in humans to resist shearing from vertical compression, that is gravity, and anteriorly directed forces on the spine. Okay, but it's most important to understand that stability and flexibility are simultaneously counter-opposing states in the sacroiliac joint and place conflicting demands on its joint construction. So these are very highly specialized joints that permit stable yet flexible support to the upper body, as well as a base of support for the legs to swing from and absorb ground reaction forces. So in summary, the sacroiliac joint, to balance stability with flexibility, will depend on normal myofascial and ligamentous viscoelasticity, normal neuromotor modulation of bracing of the joint, balance and free function of the skull and spine on the pelvic base, freedom of action of all the limbs and their attachments to the pelvis, normal proprioceptive feedback from the inner ear, the upper cervical spine, plantar reflexes, and of course the sacroiliac joint. Any disruption of any of these five factors may result in pain and dysfunction of the pelvic soft tissue articulations and joint surfaces, and is often a consequence of a sudden or cumulative strain and microtrauma, or as a result of accident or poor postural use over many years. However, there's another very important but neglected clinical factor that must be taken into consideration, and that's autoimmune collagen disease and its effect on connective tissue. It can frequently be the background to degenerative and inflammatory mono and polyarthralgias, including that of the sacroiliac joint, of which we see in clinical practice in a minor form, in a subclinical form. These are extreme examples: psoriatic arthritis and ankylosing spondylitis. Okay, but we see subclinical states of early stage autoimmune collagen disease. And it's frequently missed by us in the diagnosis of sacroiliac joint pain and dysfunction. And you've got to be wide awake to its possibility. And boy, if you start to treat that with high velocity or heavy manipulations, it can be disastrous. And I've done it more than once. I've misdiagnosed, I've misunderstood the pathology underlying the pain, I've missed the fact that it was an early stage autoimmune collagen disease, and it's probably behind a lot of the pain syndromes that we see. And the patient is unwell apart from having significant pain. There are some warning signs, some early red flags, you could say. And its treatment is quite different. It may necessitate as a priority what Littlejohn would call palliative treatment, sedating and remodulating the body's immune response before you start to think of local pelvic manipulation. In other words, slowly but surely raising the health of the patient so that the immune system is not reacting incorrectly to the body's own tissues, and only at a later stage may there be any significant local treatment to be applied. Now we come to the most juicy bits. If you're still all awake, if not, this will certainly wake you up, I think. Let's look at some of the morphological factors that are usually ignored in osteopathic teaching and which do call into question many of the theories and diagnosis and treatment procedures. So, okay, we've already mentioned the minuscule movement present in the ideal sacroiliac joint, let alone one where there's superimposed degenerative changes, as in most adults beyond the age of 40. But to make things more complicated, if we were to rely on surface anatomy for our diagnostic or treatment criteria, we would be ignoring the fact that bony anatomy is highly variable in size and shape, not only among individuals, but even from side to side within the same individual. For example, variations from side to side of the size and shape of the auricular surfaces or of the ilia make it very difficult to determine the so-called normal of the individual patient. Take a look at this. It's from Fryet's famous book, where he's looking at the variation, the significant variation in the angle of the sacral joint, not only from the normal, which is considered to be the one on the extreme left, but even from one side compared to the other, as the third picture on the right shows. Try to think to yourself how numbers 2 and 3, picture 2 and 3, would affect the biomechanics that you're palpating. And whether in fact you're going to diagnose something as faulty or wrong when it's perfectly normal for that individual. So it's perfectly logical to expect that these normal morphological variations will produce seemingly visual and palpable so-called abnormal and asymmetric movement and compensation patterns, even beyond the pelvis and lumbar spine. Here's another look at them. Look at the convexity, the hill. In this joint, the valley. and hill. There's a small valley, there's a small hill in this joint, and the deep valley in this joint. And consider what that's going to do to iliosacral movement. And especially if one side is quite different from the other side of the same patient. And now we'll come to a real old favorite. Another source of potential illusion of lesioning is the measurement of iliac heights and position. So we looked earlier, right at the beginning of this lecture, how asymmetric muscle coupling tension can produce a false impression, not least that of acute or chronic hypertension of quadratus lumborum or psoas, and greater or lesser degrees of lumbar scoliosis. But there are other diagnostic traps. Not infrequently, one ilia is larger than the other, just like a foot is often bigger on one side, or a hand size is often bigger on one side compared to the other. This will readily give the illusion of an upslipped ilia, or a longer leg, or a posteriorly mutated ilia. The actual size of one posterior superior spine can be larger and protrude more than the other side. And on palpation will suggest mutation of the ilia posteriorly. But it's in fact just larger. The bone is bigger there if you measured it on a skeleton. It can give this impression of a posterior or an anterior mutation. A larger and more prominent anterior superior spine, because the bone is just bigger on one side than the other, may give the impression of anterior mutation. And what is forgotten and hinted at in that very first film I showed of that contraption supposedly measuring the function of the sacroiliac joint is that if these kinds of major bony movement shifts were to have happened in reality, it would have caused excruciating ligamentous tears. It would have produced partial joint dislocation and certainly serious injury to soft tissue enthyses. Now, you may have asked me, well, maybe they're very rare, these morphological changes. Well, just take a look at these figures. Okay? Your normal comes out at roughly 50%, 57% of all skeletons that we tested. But look at the percentage of this kind of abnormality. 31% of the population showing this kind of abnormality, and 12% showing this. So we're talking about 44% of the population, roughly, showing abnormal variations in some sacrolumbar facets. Sacrolumbar facets. Imagine what that's doing to the biomechanics of the lumbar sacral articulation and the movements of the pelvis and the movements of the lumbar spine, for that matter. And finally, let's take an important but very common visual illusion produced by the influence of thoracic and lumbar scoliosis on the pelvis. I'm sorry, just going back one, again, further facet anomalies. I don't know if you can see this clearly, but here's the norm. Here's a unilateral articulation of the transverse process with the sacrum. Here, bilateral articulation of the transverse processes with the sacrum. Any score of variations here that will affect the so-called normal biomechanics of movement that we're testing manually. Finally, let's look at the visual illusion produced by the influence of thoracic or lumbar scoliosis on the pelvis. What's actually happening here? The individual in this picture has instinctively turned his upper body to face directly forward in the line of his sight. Okay? He's pointing directly forward, his upper half of his body, to be in line with his side. Now, if we were to grasp his pelvis and firmly ensure that the pelvis is directly pointing forward, okay, if we were to take hands on either side of the pelvis and turn it backwards on the right to make sure the left and right sides of the pelvis were pointing perfectly equally forward, then his upper body would be turned to the right, following the course of the vertebral lumbar bodies which are rotating to the right. But it gives you the impression, the operator, palpating the pelvis, he's got a posteriorly mutated ilia on the left. And that is a total misconception and illusion. This is what's happened, in fact. The vertebral bodies have rotated to the right. He has turned his body to the left to make sure he's still looking straight ahead, and so the left ilia has come backwards to compensate. The twist is in the ilia in relation to the lumbar spine, the whole of the ilia. By the way, this is quite interesting. Normally, the vertebral bodies would rotate to the left into the convexity. But this patient is in forward bending. So it follows Fayette's, I believe it's the second law, extension, rotation, side bending into the cavity. It's my hope that this lecture will have pointed out the need for us to be most careful in our subjective diagnostic procedures, and that there's a large margin of error that can result. In my opinion, we're likely to be closer to reality if our diagnosis is based on detecting malfunction and malcoordination, both local to the area of pain and disability, as well as in the context of the rest of the body mechanics. Treatment of pelvic pain and dysfunction in turn requires the careful, precise, and methodical attempts at integrating all the conjoint biomechanical activities of spine and body with the pelvis, and all of these in relation to the central gravity line. Students at Still and Littlejohn were often at a loss as to why they both devoted so much time and effort at examining and treating the whole body when a patient presented with a seemingly local pattern and problem. I really hope I've clarified a little with this presentation some of the reasons why they spent so long examining and treating the whole body. If I haven't, then that's probably the result. Thank you very much. I left a little bit of time for questions, I think 2 or 3 minutes, or longer, depending on you, but if there are questions, I'll be most happy to try to answer them.
Thank you very much, Mervyn. That was great. Thank you. I enjoyed that lecture. Thank you very much. Yeah, pinpoint a few very interesting points there. Yes. So let's see if anyone has got any questions for Mervyn, so we can say something.
I'm open to abuse as well.
No, I like those points that you raised, like a total body response, you know, key concept that they keep coming up in osteopathy, in classical osteopathy. And also the fact of approaching the pelvis with long lever. It does make a difference, I think, yeah.
Has everyone dropped off to sleep, or are they in a state of shock?
They're in shock, yeah. Well, let's see. Can you give directions how to manage bony differences, right, left, in clinic?
Ignore them.
No, then.
Treat the pelvis functionally in terms of its function, which in turn will tell you, firstly, where there is pain and where pain is being generated, and where you might have to try to work out why pain is being generated. But don't look at bony anomalies. Don't look at the anomalies as significant. They are insignificant. What is important is how smoothly and rhythmically does that pelvic function in terms of its symmetry of function and then in relation to the rest of the body. Our work is to restore balanced mobility, where possible, where determined by the age of the patient, the pathology of the patient, within those limitations. A 90-year-old patient with gross morphological changes and degenerative changes has gross asymmetry. On X-rays, you can see it. You're never going to change that, whatever you do. But we hope to improve function to a small degree, balanced mobility where possible, and that will often make all the difference in their lives.
Yeah, we have another question. You talk about early red flags for subclinical autoimmune presentations. What would you consider those to be, those red flags?
Well, some of the red flags involve the general health of the patient. You've got to spend time in your initial and later meetings with the patient of asking general health questions. The state of their health will often indicate that something more serious is going on than a purely orthopedic problem. They're run down, they're unduly tired, lacking in energy. Often depression is in the background. Their digestive system is often not working well. People with autoimmune conditions often have a number of them playing up at the same time. It often is accompanied by irritable bowel syndrome, or Crohn's disease, or celiac disease. It will come up with an indication that their general health is also disturbed. And that is a red flag. To look deeper, to send the patient back for more blood tests to the GP, to suggest blood tests like C-reactive protein and CPK, ESR levels. The doctor will appreciate, if it's written politely, that you're worried that there may be early signs of an autoimmune collagen disease. And he'll take the trouble, it doesn't cost him anything, to send the patient off for some very important blood tests.
Thank you. Yeah.
And don't forget, this can just as readily be children. Juvenile arthritis is much more prevalent in its early clinical stages, and a warning signal should be for anyone anyway. Painful joints in children, it shouldn't exist. It's very rare. So if it does turn up clinically, that is already a warning signal that there's something more going on there of a systemic nature. Which doesn't mean you haven't got treatment to give the patient, osteopathic treatment that affects their health and hopefully improves their immune system. But it involves the total adjustment of the patient. It really does involve understanding Littlejohn's use of the word adjustment in its broadest sense, including those factors in the patient's lifestyle that are so significant in the health of that patient, not least the dietary factors and other lifestyle factors that affect and influence health.
Yeah, you mentioned that neuroregulation of the system.
Yes.
Yeah.
Basically, to cut it in short, most of our work is an attempt to improve neurosignaling. Most of our patients are in pain for one reason or another, including those who are suffering an infection. It's just as relevant when we're treating a a patient with flu, or a child with an upper respiratory tract infection or a throat infection, that we still are trying to re-regulate neurosignaling, whether it's from nociceptors in the area of infection or inflammation, or whether it's from a joint that is suffering injury. Basically, the bottom line of our work is to re-establish improved neurosignaling. Interesting, of course, that Littlejohn saw disease as always starting on the sensory side, as aberrant, afferent impulses entering the spinal cord and moving up to upper centers in the brain too. But he saw that as the first stage of any condition and pathology. And we enter the picture, hopefully as Littlejohn did, the moment we try to alter that signaling in a more favorable manner. Inevitably, that means the treatment has to be sedative. Very rarely, there are occasions, but it's very rarely that it is anything but sedative. And that, of course, is where rhythmicity and a skilled pair of hands is so important, but also timing. The moment we overtreat, and it can be a matter of a minute or two, it can go terribly wrong. And the neurosignaling that was sedative becomes irritative. It really is a skill and well worth watching an experienced operator to see just how precise and short the maneuvers are when they're applied properly. Constantly afraid of overtreating. Well, if everyone's dropped off, they've dropped off, just as that picture suggests.
Okay, thank you very much. I think we don't have any more questions. I don't see any more. So,
and of course, Diego, of course, this will all be available for anybody to see it at a second shot with the text attached to the PowerPoints. Okay,
yeah, we will put this video webinar into the Vimeo account of the ICO, available for everybody. And thank you very much for watching and logging in today with Mervyn Waldman. And as I said, we hope to see you in the ICO conference in 2 weeks' time, the spine as the axis of life. Check more details in the ICO website, and we have more webinars and more workshops coming up towards the May and June. So everything will be there. Thank you, Mervyn. Have a nice evening.
Thank you.
And see you soon. See you in London.
Bye-bye.
Bye-bye. Bye.